say it except Thank you.
Thank you. So we're going to speak about marrow edema. And the first concept is there's a distinction between what radiologists call marrow edema and what pathologists call marrow edema. And that disconnect has led to some misunderstandings. So we're going to begin with what is marrow edema. And then, if you remember nothing other than this talk, whenever you see marrow edema, there should be a list of 7 things it could be. And your job is to take decreased that list. Make it 6, make it 5, make it 4. But just remember those 7 things. We're going to speak about the role of sequences, variants, and some pearls all together, and with morphologic clues, and then end if we have time with what causes symptoms. So here's an example of a lateral ankle sprain. You see the fluid goes up. That means the anterior talofibular ligament is torn, and we can see compressive bone bruises on the opposite side of the ankle. And compressive bone bruises are larger and more frequent than tensile bone bruises. So first the definition. So on histology, marrow edema is breakdown of the epithelia of vessels that feed marrow. That's what it is on histology. We see fluid in the interstitial space. When you fix tissues, that fluid goes away. The formalin, causes fluid to evaporate. That's one of the things it does. So, if you take a biopsy of a bone bruise, a pathologist will see disruption of trabeculae. They may see hemorrhage, but they won't see fluid in the interstitial. Hence, there's a few things that cause marrow edema on imaging that don't cause visible marrow edema on histology. And this is one of them. So this is a T1 wave image and a T2 wave image, and this is red marrow. And you can see that the red marrow is unusually excessive and unusually bright. And I have proof that this is red marrow because 7 years later it went away and it turned to fatty marrow. So red marrow is one thing that can cause marrow edema on imaging, but not on histology. And this is something that will cause an abnormality on histology, but not marrow edema. So if the pathologist looks at this, they will see dead bone. They will see the transition zone, the reparative zone, but they'll see nothing in the rest of the talus. The rest of the talus will be normal histologically, even though everyone in this room recognizes how abnormal it is on imaging. So marrow edema is leakage of fluid from vessels. So it's into the interstitium. It's breakdown of the epithelial external lining of vessels. It's not hard to see marrow edema. You can put up this image outside this fine university, and someone on the street will say, well, there's something wrong here. They may not know what it is, they probably don't, but they'll be able to see that there's something wrong. And what that means is it's not hard to see marrow edema. It's hard to diagnose what caused it, but it's not hard to see. So we're going to concentrate on how to diagnose what caused it. Anyone know what causes this? So, think of it, insufficiency factor, right? Horizontal oblique meniscal tear. You see the collapse of bone, insufficiency factor. This is a really hard one. So if someone gets this, they'll get a prize. It's commonly seen with HIV. Raise your hand. So here is the abnormality, and you see how bright it is on T2. Anyone? Want to do a star? What's that? Good thought, but I wouldn't say it was if I gave you the hint that it's really hard. It could be osteomyelitis in the right setting. This is serous atrophy. Serous atrophy. It's when the marrow dissolves. This was following radiation therapy, but typically associated with HIV disease. Marrow just dissolves. Serous atrophy. Okay. When you understand marrow edema, we talked about fluid with a slide and a copper slip earlier today, right? Yes? Yes? Yes, we did, Mark. Yes. Okay. You live in a desert country, and marrow edema is like a rainstorm in the desert. So the ground dries up, and you see cracks in the ground, right? And when you get a rainstorm, the water goes into those cracks. And then at the edge of the crack, it kind of forms a puddle. Is that what happens? And that's what happens with marrow edema. So your bone is dry, it gets some fluid in it, and that fluid goes along lines. Those lines could be trabecular, those lines could be cortex, those lines could be a fraction. But it goes along those lines. And the fluid is viscous. It's like motor oil, it's thick. So it flows slowly and pools easily. So if I spilled oil on the ground, it would stay in a puddle. If I spilled water on the ground, it would spread out. So it acts more like oil after a rain or after a drought than water after a drought. So here's an example. This patient has calcaneal cuboid osteoarthritis and has kissing edema on either side. At the end of this talk, one morphologic thing we'll speak about is kissing. When you have kissing abnormalities, it's almost always arthritis, usually osteoarthritis. And you see the marrow edema going along the trabecula. Can you see that? And that's like that cracked ground in the desert. And then it goes along the cortex. Can you see it going along the cortex? Because that's another hard structure. And it doesn't pool much. It pretty much stays where it is. Can you see that? Does that analogy work? Yes, it does. Okay. So here's a person who has atraumatic osteolysis of the clavicle. And here's the marrow edema. And again, it goes along the trabeculae, and then it pools along the cortex. This is a patient who had a fracture, and the oil or the water goes along the fracture. Any line it will go along, whether that line be trabeculae, cortex, an osteochondral defect, a fracture. Here's another person with a fracture, and it goes along the fracture and pulls adjacent to the bone. Now, when you have marrow edema, you have to know a little bit of anatomy. So you'll get more marrow edema where you have cancellous bone than when you have cortical bone. And the best example of that is in the spine. So when you have a fracture of a vertebrae, is it easy to see the vertebral body part of the fracture or the posterior element part of the fracture? Help me out. The vertebral body part of the fracture. Because there's a lot of trabecular bone there. It's cancellous bone. So you get more marrow edema. The fracture isn't any worse in the vertebral body than it is in the posterior element. It's just the fact that you get more marrow edema when you have cancellous. The second thing is you get a lot of marrow edema underneath the cortex. And that's also because you have a lot of cancellous bone underneath. And the third thing is the vector also determines the marrow edema. When you have a compressive vector, you get more marrow edema than when you have a tensile vector. So when looking at marrow edema, the two things you should try and remember is this area have a lot of cortical bone or not? And was the vector likely compressive or tensile? So here's an example. Posterior ulnar fracture, vertebral body fracture, and obviously you see the vertebral body fracture as stated correctly by several of you because it has more cancellous bone, and then there it is. So here's a patient who's got ulnar positive variance, a TFCC tear, and we can see the changes from abutment in the lunate, right? But no marrow edema in the ulna. If two things are banging on each other, there's no reason why one should get banged more than the other. But the reason is the ulna has very little subchondral trabecular bone. And the corpus is full of trabecular bone. So when you get abutment, and most of you probably have seen this, you're going to get many more changes in the lunate than the ulna. And that's just because there's more trabecular bone there, the exact same thing that we saw in the spine. So here's a very common occurrence in Detroit that I guarantee you is very uncommon here. Frostbites. So this is a person who has frostbite of the toe. And we'll talk about this, I think, a little bit tomorrow in the infection. And you see the tremendous marrow edema in the distal phalanx because the distal phalanx is full of trabecular bone, and the other phalanxes are predominantly cortical bone. So they had frostbite and got amputated here, but this is marrow edema from trabecular bone. And the last thing is vectors. Compression vectors give you more marrow edema than tensile vectors. So lateral ankle sprain, like we showed before, anterior talofibular ligament, calcaneofibular ligament, both torn, but the marrow edema is much worse contralateral to the tear because when you sprain your ankle, the compressive vector goes in medially and it causes tensile failure laterally. So bone bruise is always worse from compressive than tensile forces. And I talked about elbow and triceps injuries. So this is a piece of bone that is a bolt off of the left. Do you see a little piece of bone? It's a pretty big fracture, right? And not a lot of marrow edema for a big fracture. And the reason is triceps avulsions are tensile. So they're not going to cause much marrow edema. Okay, so there is a difference in the histologic and the imaging definition of marrow edema. Marrow edema tends to predominate in trabecular bone. And marrow edema is worse when you have a compression vector than when you have a tensile vector. Now remember the first thing I said, it's different pathologically than histologically. So half of these 7 things that I'm going to give you, and this is the only thing you need to remember to be honest, is they're not seen histologically. Now I work, at Wayne State now, and I work on the Henry Ford clinically. That's why I do my Wayne State is the biggest medical school in America, and so we have 7 hospitals. And the one I worked is at Henry Ford. And years ago, I gave a similar lecture to this at Henry Ford. That was my first visit there. So here are your 7 things. 1 is normal, and we showed an example of that with red marrow. 2 is AVN, and we showed an example of that in the tail. 3 is arthritis, including inflammatory arthritis, infectious arthritis, and osteoarthritis. 4 is tumor. 5 is infection, osteomyelitis. 6 is injury, fracture, bone bruise, stress fracture, any of those. And 7 is reactive. And reactive means there's a soft tissue process and the bone is responding to that soft tissue process. So this one I showed you earlier, I believe I showed you the exact same slide. So here is the soft tissue process, Simons-Tarski syndrome, and the bone marrow edema, the bone is responding to that soft tissue process. So of these 7 choices, 2 of them are occult histological. Normal and reactive, the pathologist does it. So let's talk about normal for a minute. We'll get back to it again. Penetrating vessels, intramedullary vessels can cause marrow edema. Red marrow, showed you this in the elbow and in the knee already, can cause marrow edema. Rapid growth in adolescence can cause marrow edema. We'll show you examples of all of those. They are normal. So this is excessive red marrow. This person was anemic. And you can see how bright the red marrow is. Can you see? You would call it edema. This is normal. It's just red marrow. You see this in a scaphoid. You see that it's a vessel on T2. You see the extra osseous vessel going into the medullary cavity. So penetrating vessel can cause marrow edema. Very common in the lunatic as well as the scaphoid. This is not normal. This is AVN following a hamartome repair, but the second choice. This is post-traumatic osteolysis, another example of one that we showed, and this would be in the trauma spectrum, type of stress, injury. This patient has both arthritis and red marrow. And note how the edema is going along the physeal scar. Can you see the edema going along the physeal scar? Because that's another line. Edema goes along lines. And be careful that you don't mistake this line for like a fracture line. But you know that the physeal scar is there. And this is reactive. This was mentioned in the excellent talk by Reem earlier. This patient has Haglund syndrome. Very common to get this little focal filming defect in the retrocalcaneum bursa, and we see marrow edema in the calcaneus. Now I want to mention one thing about reactive marrow edema that's very helpful. It's either subtle or occult on T1 weighted images, which is a good reason to still do T1 weighted images. Like you might see this edema here, but it's pretty subtle. The other causes of marrow edema should be visible on T1 weighted images. Another case of reactive marrow edema, painful ospironium syndrome, but I'm showing you the marrow edema in the calcaneus, reactive to a soft tissue function. So the 7 causes, again, anyone want to try and yell them out? Normal, infection, trauma, tumor, necrosis, arthritis, and reaction. Right? So every case of marrow edema, think of those 7 and start crossing them off, and then you'll have the differential diagnosis. Now, one way of crossing them off is to look at the different sequences. So I used to work in a big orthopedic hospital in Manhattan that Dr. Sammy knows well, called Hospital for Joint Diseases. And our competitor was another big orthopedic hospital in Manhattan. It's called Hospital for Special Surgery. And they only did proton density imaging. That's all they did. No T1 weighted imaging, no contrast, only proton density imaging. And the only option was either with or without vaccination. That was the only variable. And I try and be open-minded and say, well, they have a reason for doing that. But I think if you're looking at marrow, you're doing a disservice. Because the T1 weighted image narrows your differential diagnosis and helps you be more specific about your diagnosis. So I think all you need to do is one fluid weighted image, one T1 weighted image. Very rarely do diffusion imaging make a difference compared to T2 weighted imaging. But in and out of phase imaging is very useful. And we'll have some examples for that too. So certain things that you see well on T1 weighted images are bone parts. So if you see this in a calcaneus, the tibia I think is obvious. The calcaneus less so. Anyone have any idea what the underlying disease is here?
Sickle cell?
Excellent. The only thing that gives you influx of the calcaneus is no other disease in my 40 years. Fluid-weighted imaging is very sensitive, except for metastatic disease. Because there are sclerotic metastasis, you may not see them on T2-weighted imaging. So when doing a metastatic survey, T1-weighted imaging is mandatory, T2-weighted imaging is optional. The T2-weighted image tends to be nonspecific. There may be secondary signs on it, but usually you need a T1-weighted image to help. What does help on a T2-weighted image is to see the soft tissue processes happening around the marrow edema to see if it's reactive. So here's another calcaneus case, and this is a stress fracture of the calcaneus. And another pearl is lines tend to be better seen on T1-weighted image. Whether that be a fracture line, an osteoclavicular defect line, a normal line, you see this on both, but I think it's more obvious on the T1-weighted image. So if you think I see a traumatic lesion, you see a traumatic lesion, is it a bone bruise or a fracture? And one way to distinguish them is how obvious the lesion is. The more obvious, the less likely it is to be a bone bruise. And T1 is a way to see how obvious the lesion is. So if I see something on T2 and I don't see it on T1, it's more likely a bone bruise. If I see something on T2 and it's very obvious on T1, it's more likely a fracture. Now you don't have to have a fracture line to call a fracture. If it's in a bone where undercalling a fracture makes a really big difference, I will call it a fracture. And one example is the skateboard nerves, right? You don't want to mistake a bone bruise for a skateboard fracture and have the person get invasive process. So you don't need to see a fracture line to determine if it's always a fracture. Same thing for stress injury. You distinguish between a stress response and a stress fracture, not by the fracture line, but by the T1-weighted image. And as we said before, mets are better seen on T1, avascular necrosis is better seen on T1, and lines are better seen on T1. So if you saw this T2-weighted image, I think you would call this elbow normal. If you see this T1-weighted image, it's avascular necrosis of the capitellum, and it's just so sclerotic, there's no edema on it. Again, reinforcing the concept that avascular necrosis is better seen on T1-weighted image. Fracture lines, stress fracture, not seen here on a T2-weighted image, better seen and only seen on a T1-weighted image. This is skeletal carcinomatosis. So how do you grade the severity? Well, do I see it on T1? How big is it? But remember to put that cancellous cortical compressive versus tensile variable into that equation. We're trying to see how severe it is. So here's a person. T1 is there but subtle. They do have a bucket, by the way. Here's the T2. And we have some articular cartilage disease here. But this is a bone with very little trabecula. We spoke about this. So you should say, well, I know they have a bucket, but these changes can't be from a bucket. A, because they don't predominate in the lumen. And B, is it's far too much in the ulnar, even if they did work in the lumen. And hence this is likely an occult fracture. So this is an MR orthogram. Happens to show a scapulonate ligament tear. T1-weighted image then. And here is the T2-weighted image. Professional basketball player. Not much on T1. So would you risk this guy's career to call this a bone bruise? Or would you call it a occult fracture and make him rest? You call it a occult fracture, even though the T1 is normal, because the sequelae of undercalling it is great. Okay, now variance. So we talked about the 7 choices, I'm going to repeat this multiple times, right? Infection, tumor, trauma, reactive, arthritis, avascular necrosis, and normal, right? So in that normal is the variance. So let's talk a little bit about the variance. So one is red marrow. We showed you that a few times. But let's kind of go in more granular detail about where you might see red marrow that's present. The medial humeral metastasis, all the time on shoulder MRIs. Coracoid is the last place for red marrow to convert in the shoulder, and hence it's common to see red marrow there. Proximal radius, we showed you in the elbow. Distal humerus. Posterior medial distal femur, we showed you that earlier today. And there's 2 bones in the body where you get subarticular red marrow. As a general rule, epiphyses convert to fatty marrow first, right? Even in a 6-month-old, many of the epiphyses are converted. But there's 2 locations where subchondral red marrow may persist, and that's the subcortical surface of the humerus and the femur. So those could be mistaken for articular disease, so just be careful about that. So here is red marrow in the medial humeral epiphysis. And out-of-phase imaging is very useful when you have marrow edema and you want to prove it's not a tumor. Because tumors act like bulldozers, they push. Most other causes of marrow edema infiltrate. They just kind of spread around, sprinkle, we say in English. So if they sprinkle and you do an out-of-phase image, there'll be fat interposed with the edema. And it will drop on an out-of-phase image. If it's tumor and it pushes out of the way, there's no fat there that interposes. And hence it won't drop on an out-of-phase image. And here you see the dropping on the out-of-phase image. It doesn't confirm that it's red marrow, but confirms that it's nothing there. Okay, second variant is penetrating vessels. We showed you an example of this in the scaphoid already. And that occurs in a proximal humerus, typically posteriorly. The waist of the capitate. I mentioned the lunate previously, posterior. The edges of the calcaneus. And we saw one in the scaphoid already. So I like this case. This is a T2 weighted image. This is a T2 weighted image with vascular. So this is a penetrating vessel. This is a penetrating vessel. This is a penetrating vessel. And this is a penetrating vessel. This is arthritis. This is arthritis. This is arthritis. This is a penetrating vessel. And this is a penetrating vessel. So just you have to learn anatomically where the penetrating vessels are. And you can have more than one disorder in a patient at the same time. Now the next normal thing that looks like pathologic marrow is rapid growth. And this is akin to a stress response. So if any of you have teenagers who had a growth spurt, they kind of walk like a Frankenstein a little bit, because they're not used to their body, right? Their body suddenly grows. And they go, hey, I was 4 inches shorter a few months ago, and I don't quite know how to handle. And that causes marrow edema. And so here you see this in a child, adolescent. It has a very characteristic pattern when you see it. And that's just growth. It has several patterns. It can look like holes when they're older. You see, if I said this was leukemia, you might believe me. Would you believe me? I got an honest faith? No, it's rapid growth. So earlier rapid growth, more diffuse. Later rapid growth, holes. And you can get the same thing because of rapid changes. This is an old case, but I'll never forget it. It was, if I remember correctly, a tibial MRI that we were doing. And this was the last cut. The last cut happened to go through the hind parts. And on the last cut, we had this. And a colleague of mine used to say, well, if the MRI doesn't tell the answer, you should order an MRI. That was one of his phrases. So we ordered an MRI, a follow-up MRI. to see what happened, and it completely resolved. And when we looked at the history, this patient had a cast on and had the MRI taken off, had cast taken off, and the MRI done to see if it was infectious or not. And they just started walking on this leg. And the same as your teenager just started walking. It's really the same principle, different application, but the same principle. We did a study later on where we put an orthotic in people's shoes, and we MR'd them before and after the orthotic. The same thing happened. So altered mechanics is the same as that rapid growth. Okay, so let's do a few pearls now. We talked about the definition, the 7 choices. I'm going to keep on repeating them, right? Normal, infection, arthritis, trauma, tumor, necrosis, and reactive. And again, those 2 categories, the reactive and the normal, don't match histologically because there's this different definition between imaging and histology. So let's talk about some pearls then. T1 and T2, roughly the same. Chronic osteomyelitis, subacute fracture, treated tumor. What do they all have in common? Healing. So when T1 and T2 are roughly the same conspicuity, there is some healing. So here is T1, here is T2. You can argue this is chronic osteomyelitis. We see the ulcer, which is the best thing to distinguish this from neuropathic. And this you could then say is chronic osteomyelitis. If the T1 was more obvious than the T2, this would be more acute osteomyelitis. Here's T1 of the cuneiform and T2 of the cuneiform. They're roughly the same. So this will be a subacute fracture, a healing fracture. Healing is what makes T1 and T2 be. Now, what about if T1 is minimal compared to T2? We've spoken about this. It's reactive. It could be a bone bruise. It could be a stress response. Or it could be osteitis as opposed to osteomyelitis. Or articular disease, which some people may say is reactive to cartilage loss. I don't have a picture, I'm sorry. We mentioned this also earlier. Lines, better seen on T1 weighted image. Whether that line be from avascular necrosis, whether that line be an infarct, whether that line is a fracture or an insufficiency fracture, or whether that line is from an osteochondral defect. So here's a calcaneal fracture, line better seen on T1, and then I'm fully with it. And Dr. Sammy mentioned the ghost sign. The ghost sign is a very good way to distinguish osteomyelitis from neuropathic disease. Because in neuropathic disease, the bones get destroyed. Right? We talk about the 5 Ds of neuropathy. And one of those 5 Ds is destruction. So no matter what you do, the bone should not look normal in shape if it's neuropathic. If it looks normal in shape, it's not neuropathic. And then often the differential diagnosis is osteomyelitis. So you look at this, and I don't know, can you make out where the capitate is? Can you make out where the hamate is? No. And then you do a T2 weighted image, and the ghost of the bones come back out of it. You see, like, and it looks white, so it's kind of like a ghost. So the ghost of the bones come out of you, and that tells you that this is septic arthritis. Rapid evolution. It's very hard for students to understand that tumors do not rapidly evolve. If something rapidly evolves, it's not a tumor. It's not what Schwarzenegger said in kindergarten. Right? It's not a tumor. It could be trauma, it could be infection, it could be necrosis, but it's not a tumor. So let me just show you this example. So this person came in with a mid-thoracic spine marrow abnormality, right? Could be a pathologic fracture, definitely. Right location, right appearance. 3 weeks later, you're seeing more fatting, right? Yes? Can you see that back here there wasn't fat, and now there's fat? Yes? So it's not a tumor, it's not a pathologic fracture. And just to confirm that, they're getting a second fracture right below it. You see the fracture right below it? Benign appearing, but a fracture. So if it evolves rapidly, it's not a pathologic fracture. Tumors do not evolve rapidly. That's why if you're not sure, a short-term follow-up is a good thing to do. And here's another case. We can argue about whether this is avascular necrosis or an insufficiency fracture. I thought this was an insufficiency fracture. And you follow it up, and the marrow edema goes away, and you still see a little bit of it. The point is not what it is. The point is that trauma evolves quicker. Okay, now we're going to do morphology and symptoms. 6 minutes. Where is it? What bone is it? Because certain bones get certain things, right? You don't get abutment in the capitals. You don't get occult fractures in the cuneiforms of the foot. You know, there's certain things that you can tell by the bone. Which part of the bone is it? Particularly the edges of a bone are different than the central aspect of the bone. Is it reactive? Do I see a soft tissue process adjacent to it? Do I see a line? What happens on outer phase imaging? Is there a crescent? And then is it kissing? And then we have American kissing, and then we saw kind of Egyptian kissing before, right? So you kiss the person on the cheek, right? That's traumatic. When you kiss the person on the lips, that's arthritic. So like this is arthritic, like this is traumatic. So we can call that a continental kiss. I don't know what the preferred term is, but as long as you get the idea. So this is marrow edema in the posterior aspect of the humerus, posterior lateral aspect of the humerus, far away from the rotated column. So you know it has to be a Hill sepsis. There's nothing else that occurs there. There's no osteomyelitis, no arthritis, no reactive, no nothing other than a Hill sepsis. And here's the European or Egyptian kiss, right? Here's one cheek. They don't align with each other. Traumatic. Dr. Sammy showed you this. This is bone bruises from an ACL tear. Now we have at the edges of the bone, right, at the very, very edges, and one bigger than the other. So if you had at the edges and they were the same size, it's arthritis. When you have at the edges and one is bigger, this is the impacted bone bruise, and this is the avulsive bone bruise, and I think you can see the fracture here from the avulsion. So putting it all together, you can tell what it is morphologically. And again, the European kiss, traumatic, right, medial patella, lateral femoral condo, probably a little bit of impaction. Here, medial patellofemoral ligament tear. This is a spontaneously reduced patella dislocation. Inferior patella, anterior tibia, right? Hyperextension injury, the most common ligament tear. Trick question. Anyone want to fall into the trap? The ACL tears are so much more common than PCL tears. Even in hyperextension, you're more likely to get an ACL tear than a PCL. So you should think ACL versus PCL, but statistically ACL more than PCL. And we've showed you this now 3 times. Compressive bone bruises in the ankle, you can see. We do a lot of ankle imaging. Kissing changes here. This is a type 2 lunate, and you can see the geo within the marrow edema. And likely you would surmise that there is more trabecular bone in the ham ankle than in the lunate. Now the last thing, we got 2 minutes, is what causes symptoms. Well, it's pretty easy. Marrow edema is pretty symptomatic. As a general rule, there's really very few people with marrow edema who don't have symptoms. And the other thing that's a marker for symptoms is effusion. Very few people have a swollen knee. That edema will convert to fat. Later, you'll see it on a T1 weighted image. Earlier, you'll see it by measuring the drop by out of phase imaging over time. And a lot of people have more than one disease happening at a time. So if a person has a PTT tear and plantar fasciitis, and the fasciitis is marrow edema, the symptoms are likely coming from the fasciitis and the marrow edema, not the PTT tear. So it's a way of finding what is the symptom generator in a given person. So in the last 45 minutes, we went through the definition of marrow edema, which is leakage of fluid into the interstitial space. We said that it's different than the histologic definition, which gives us two of the differential choices that a pathologist won't see: normal variants and reactive. The other ones are tumor, trauma, infection, necrosis, and all. Then we talked about using T1 weighted imaging, better for tumors, including metastasis, better to see lines, better to see necrosis. And we gave you a few pearls, of which I think the most important one, other than the line being seen best on T1, is rapid evolution means it's not. And then we finished with put all of this together with morphology, particularly which bone and where in the bone it is, to get your differential diagnosis, and stressing that edema is a painful disorder, particularly if it's symptomatic. And I'll leave you with a last pearl. I used to do a lot of procedures. I once wrote a book on procedures, don't do them anymore. But when you do a bone biopsy, you infiltrate the lidocaine down to the periosteum, but you never put lidocaine in the marrow. Why don't you put lidocaine in the marrow? Because you're causing marrow edema. So you're going to cause more pain than the lidocaine is going to relieve. And that should reinforce the concept that marrow edema is a painful matter. Thank you for your attention. We'll continue